pain as such, because pain is one of the very, very important aspect of palliative care. So we do have few sessions in palliative care, and so we will be dealing with it in detail. So the initial one would be the introduction to palliative care, for which we have got an eminent speaker for all of us today. Warm welcome to Dr. Jewell Joseph. He is the assistant professor in Christian Medical College, and he's also a faculty in Impact for the HN courses. And he has completed his radiotherapy from Government Medical College, Thrissur. And he also has his other interests in main interest, which is in community palliative care and home-based care. Home-based care is the heart of palliative care. That is what we're all aiming for. Warm welcome. We're all waiting to be having a good insight on introduction to palliative care. The floor is for you. Please go ahead.
Thank you so much, ma'am. Good evening, everyone. Without wasting much time, I'll just share my screen. I hope I'm audible.
Yes, sir, you're audible.
I hope my screen is visible.
Yes, it is.
Yeah. So, good evening all. Today, we'll have a short introduction to pain. The discussion is based on one of the most important symptoms that we come across in palliative, not only palliative care, in probably in all divisions of medicine. Pain is one of the most important symptoms that we come across. So obviously, it is one of the important concerns that we face in palliative care. So medical community and the medical scientific community, to be more precise, have come a long way in their understanding of pain. So we used to understand pain as a mere sensation, like an unpleasant sensation in the past, but now we have grown and we have evolved to understand pain more as an experience rather than just a sensation. So it is associated with myriad of emotions and various other things. Rather than a sensation, now we understand this as an experience. It's just like going to a restaurant, right? So even if we are going there primarily for the food, the ambience, music, the surroundings, everything makes a difference. So it is a whole experience. So it is, before we go into the management and assessment of pain, it is important to understand the pain as an experience. So this change in understanding has also been reflected in the pain definition. IASP, International Association of Pain definition, which has stood for over 40 years. It came in 1979. The initial definition was an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. It was finally changed in 2018 as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So this definition may seem a little bit confusing, but the primary understanding here is that now we understand that for pain to occur, there need not be an actual potential damage. So without a perceivable potential or perceivable tissue damage, pain can occur. So it happens in many conditions like fibromyalgia. So the change of understanding has resulted in the change of definition as well. So this is the latest definition. So now what the takeaway from this definition is that for pain to occur, there need not be an actual tissue damage. So as I mentioned earlier, that the pain is an experience. So this is a diagrammatic representation of various areas of the brain, which is associated with the pain, perceiving the pain. So you can see that almost every area in brain is associated with the perception of pain. And now we may have a clearer idea about how pain is an experience rather than a mere sensation. So apart from this physiological aspects, there is another concept called total pain, which was actually put forward by Dame Cicely Saunders, who is considered as the founder of palliative care. So the concept of total pain deals with the various dimensions of pain. So pain is not just a physical sensation, it has also a psychological, spiritual, and social dimension. So all these dimensions come together to form the total pain experience. So especially in palliative care, where we deal with, we try to deal with the patient as a whole rather than focus on a particular symptom. So this concept is really important. So understanding the various dimensions of pain is very important in assessing and treating pain effectively. So one more thing I wanted to stress before we go into the assessment and management of pain is that since it is an experience and it has multitude of factors associated with this, pain is totally subjective. So what we usually come across in our practice is that when we see a lot of patients over time, we seem to be more judgmental. So we usually associate the pain experience with the perceivable tissue damage. So this patient has a small injury, so he may not be having this much pain. So it is easy to come to that assumption, especially when we see a lot of patients. But always keep in mind that pain is subjective, and same tissue damage or same perceivable tissue damage in two different patients can result in two entirely different pain experiences. So pain is subjective. So before we go into the assessment and management of pain, I'll just would like to give you a context of the pain problem. So just an insight to how big the problem of pain actually is. So we are just taking an example of cancer, which is one of the most important issues that we come across in palliative care. So this data, you can see that in all stages of cancer, right from stage 1 to stage 4, pain is an important problem. So 23.8% of patients having cancer, stage 1 cancer has pain, which goes up to 44.2% of patients having stage 4 cancer. So overall in all stages, around 50%, half of the patients in cancer are having significant pain. And in advanced cancer, it goes as high as 70%. And again, we can see that this is a data which was published in 2016. So we can see that the pain that is occurring in cancer is not only associated with the disease process or the treatment process. You can see that here, even after curative treatment, 39.3% of patients have had pain. So during cancer treatment, it was 55%. Advanced cancers have obviously a higher rate of pain occurrence. And even in that, 38% of patients had moderate to severe pain. So this is actually an ongoing problem. So even after the treatment, or even after the curative treatment of cancer, pain remains to be a significant problem. So since we have established that pain is an important problem in palliative care, or in general, as in the especially in advanced diseases, the next question to ask is there a gap? Is there a deficiency in the way we treat pain? Since pain is an important problem, is there a deficiency in the way we treat pain? The answer would be yes. See, this data was taken from 4 cancer hospitals in India. So you can see that of all the total patients who had severe pain, only 5.7% of patients had adequate pain relief. So it was 50% in mild pain, 19.8% in moderate pain. Just imagine, 94.3% of cancer patients who had severe pain had inadequate pain relief. That is really a sad state of things, right? So we should actually see it in the context that in the past few decades, cancer treatment as such has grown by leaps and bounds. So there are newer drugs coming every day, literally every day, and we have actually increased survivals, increased progression-free survivals, and all sorts of data. But it is really unfortunate that our pain management is still taking a backseat, which will be more clear when we see another data. So the data which I showed previously in 2016 was actually a follow-up to a data which was published in 2007. So we can see that during these approximately 10 years, the prevalence of pain has not actually changed much. It was 59% in 2007 during cancer treatment, 55%. So all these data, just look at all these data, and we can see that the prevalence of pain in the past in this past 1 decade has not changed much. So again, if you look at the cancer treatment as such, it must have grown exponentially over this past 1 decade. There may be many reasons for this, but it just wanted to show you that pain control is still a great challenge in cancer patients, which is the same case with other diseases as well. I was just taking cancer as an example. So having said that as an introduction, so we will go to the pathophysiology of pain. So you must be very familiar with this particular diagram. So this is a classic pain pathway. So although I have mentioned that there need not be a perceivable tissue damage for pain to occur, for this example, let us assume that there is one perceivable tissue damage. So what happens is the nociceptors or the nerve endings of the first order neurons will perceive that injury from the site of tissue damage, which will be conveyed to the dorsal horn of the spinal cord. From there, through the ascending spinothalamic tract, which will those sensations will be transmitted to the thalamus, and from there it will be transmitted to the somatosensory cortex, where the pain perception takes place. From there, descending pathways actually come down to regulate the pain. So this is actually the classic example of pain pathway. So I would like to pose a question to you. So suppose if there is an injury, and if that nociceptive injury and the noxious stimulus remains the same over time, so what happens to pain? So see, there is an injury and it remains the same over like 1 month or 2 months. So what happens to pain? Will it increase? Will it decrease? Or will it remain the same? You can answer in the chat. Dr. Shivaranjani has told that it will increase. Anybody else? Any different answers? Dr. Surabhi has told that it will decrease. Yeah, decrease. May increase or decrease. Okay. So the answer would be, if the stimulus remains the same, pain will actually increase over time. So this brings us to an important concept, of recruitment and sensitization. So we'll go into that later. This is very important to understand because it is one of the important cornerstones of understanding pain and designing the management. So what happens here is, we'll just go back to that previous diagram. So see here, there is a nociceptor. There is a tissue injury, say a tumor or injury or anything. So again, the pain, this is the pain pathway. So in the beginning, so what pain actually is body's way of telling you that something is going wrong. So when suppose we just accidentally put our hand into a bowl of boiling water, body will tell that you are injuring yourself and to pull your hand back. So we will reflexly pull our hand back. So after that, after some time, the pain will decrease. So what happens if we cannot remove that noxious stimuli? So if there is an incurable cancer, what happens is that cancer cannot be removed. The body will keep on perceiving pain. So I'll tell you an example. So if you are in a room, and if your friend is in the next room, if you are calling that friend from your room, he's not responding, what will you do? You'll actually call louder, right? So the body does the same. So body doesn't know that this stimuli cannot be removed. So what happens is that it will actually tell you louder and louder that there is something going wrong and you need to do something about it. So what happens is primarily these two things, recruitment and sensitization. Sensitization is basically all these nociceptors, right? So they will become more sensitive to pain. So for the same stimulus, there will be more electrical impulses sent from these afferent nerve fibers. The recruitment is basically like calling extra force in times of a crisis. So the adjacent spinal segments will also be recruited. So not only the particular segment concerned with that position of that, the area of that particular noxious stimuli, the surrounding segments of the spinal cord will also be recruited to perceive pain. So what happens is, if you have a pain in a particular region and if it cannot be treated and if it goes on for some time, the surrounding areas will also become painful. So basically this is what happens. So there will be increased sensitization of the nociceptors and there will be recruitment of the adjacent spinal segments, which finally result in a greater area of pain and an increased intensity of pain. So I think, so this is recruitment and sensitization. So why should we know this? This is because we should treat pain early and we should treat pain well. So unless we treat the pain early and treat the pain well, this central and peripheral sensitization, recruitment, everything will happen. The pain will become increased, and once this happens, it will be very difficult to tackle the pain problem. So coming to the next slide. So I'll give you two case scenarios. So we'll just have a discussion. So first is a 54-year-old gentleman is a known case of carcinoma lung with bone metastasis. He comes to you with a pathological fracture of right humerus. The patient grimaces in pain, has tachycardia and sweating. He says that he is in severe pain. Second gentleman is a 60-year-old gentleman. He's a case of carcinoma head of pancreas. He's on chemotherapy for the past 4 months. Patient says that he is in severe pain, but he does not appear to be in distress. He looks tired and gloomy and has decreased appetite and sleep. So both of these patients tell you that they are having severe pain. So which of them is telling the truth? First one or the second one? So, yeah, everybody is telling that both of them are telling the truth. That yeah, that is right. So this will again bring an important concept of acute and chronic pain. So acute pain is, as we mentioned earlier, body's way of telling you that there is something wrong. So there will be sudden, what we call the typical pain responses. The patient will be grimacing in pain, crying. There will be sympathetic stimulation, tachycardia, increased sweating, everything. But chronic pain, when this goes on for a long time, will change. I mean, so we can see that the acute pain is actually a symptom of something going wrong. But chronic pain, when it goes on for a long time, it will become a disease in itself. It is not a symptom, it will become a disease in itself, in the sense that it doesn't have any useful purpose in the body. So acute pain is useful because it will tell you that something is going wrong. Chronic pain doesn't serve any useful purpose in the body. It becomes a pathological condition and it becomes a disease in itself. So important thing to understand is that it will not have the typical overt pain behaviors that we usually associate with pain. So chronic pain usually has an ill-defined onset and a prolonged fluctuating course. The patient may not be able to tell you exactly when the pain started, and it has a prolonged fluctuating course. There may be periods of decreased pain. There may be sudden increase in pain in between. The overt pain behaviors, as we mentioned earlier, will not be present usually. Vegetative signs will be present: lassitude, sleep disturbance, anorexia, etc. Patient does not usually appear in the sense, in the traditional sense, the patient may not look to be in distress. Here, the only definitive way to determine the presence of pain is to obtain a verbal report from the patient. So this is one important distinction that we have to make between acute and chronic pain. So now we'll come to the classification of pain. So in a very broad sense, pain can be classified as nociceptive and neuropathic. So nociceptive is basically pain associated with tissue injury, either soft tissue or bone. Neuropathic is the pain associated with some injury to the nerve, either a nerve compression or a nerve injury or anything like that. So this is the very broad definition of classification of pain. Nociceptive pain can be again divided into somatic and visceral. Somatic will be the soft tissue and bone. Visceral will be the viscera. So these two are they are differentiated because they have certain specific characteristics. So somatic and visceral. Neuropathic obviously is associated with nerve injury, as we mentioned earlier. So we'll just start with neuropathic pain again. Neuropathic pain can be either central or peripheral. In the sense, it can be damage in either the central nervous system or peripheral nervous system. So identifying neuropathic pain is basically based on quality, distribution, and abnormal sensation. So these are the three things that will actually give us a clue about neuropathic pain. Quality, usually in neuropathic pain, we might all have had suffered from sciatica or some other neuropathic pain. So typical neuropathic pain would be a shooting kind of pain, radiating kind of pain, or a burning sensation, the typical qualities that we associate with neuropathic pain. Distribution is obviously the region of distribution of that particular nerve. So that is one thing that will give us a clue about the nature of the pain. So neuropathic pain is typically distributed to the distribution area of that particular nerve. There will be some abnormal sensation also. Two important abnormal sensation is hyperalgesia, which is actually increased sensitivity to pain. So the less painful stimuli will be perceived as a severe pain. And there is something called allodynia, hyperalgesia and allodynia. Allodynia is perception of a non-painful stimulus to be painful, like a stroke or a touch. And hyperalgesia is increased sensitivity to pain. So those are the two findings, clinical signs that we can that will help us identify neuropathic pain. So quality, distribution, and abnormal sensation. So there is one more type of neuropathic pain, which is called a sympathetically mediated pain. It is not very common, but it is actually an important aspect of neuropathic pain. So what happens here is there is an abnormal coupling between sympathetic efferent and nociceptive afferent neurons. So usually it doesn't happen. So what happens is whenever there is a nociceptive noxious stimuli, when the signal is passed to the nociceptive afferent neurons, there will be a reflex sympathetic effect. So the pain experience, the pain reflex is mediated by the sympathetic nerve. So there is an abnormal coupling. So what happens is in that region of pain, there will be hyperesthesia and allodynia because it is a neurologically mediated pain. So there will be abnormal vasomotor changes there. There will be temperature asymmetry, skin color changes, and skin color asymmetry. So there can also be edema, sweating changes, on sweating asymmetry. So basically what happens here is there is a pain impulse happening, traveling through an afferent nerves, and in return, there is a sympathetic activity coming through the sympathetic efferent to that particular region. So in response to pain, there is a sympathetic activity. So that is sympathetically mediated pain, which actually is one of the mechanisms of another set of a specific set of symptoms, disorders known as complex regional pain syndrome. So this is one thing to keep in mind. Not very common, but still important. So coming to the nociceptive pain. So nociceptive pain, again, as we mentioned, it can be either soft tissue or viscera. We say that somatic and visceral pain, but since there is a distinction, it is better to, it is always good to have a distinction between soft tissue and bone pain, because bone pain is usually has some different characteristics. So soft tissue and bone, we typically know, right? Whenever there is an injury, it can be an aching, throbbing, dull kind of pain. And visceral pain has its own characteristics. So any if abdominal hollow viscera becomes affected, there can be a twisting pain, colicky pain, etc. We must all have experienced some abdominal colic. If it may not be always colicky, twisting pain, etc. But if other visceral organs like liver capsule, etc., are affected, it can be a dull aching pain also. So soft tissue. This is basically nociceptive pain where there is a tissue injury. Other one was neuropathic pain where there is nerve injury. So I'll just mention two specific things about bone pain. So usually we say that we usually put bone pain under somatic pain, but usually it has a neuropathic component as well. So the neuropathic, it is very usually evident in conditions like bone metastasis. What happens is the neuropathic component is because whenever there is some injury or a tumor deposit in a bone, there will be some microfractures there. So it can actually cause direct nerve injury, and because of this microfractures, there will be pathological sprouting of sensory and sympathetic nerve fibers. So it's always better to keep in mind that bone pain usually has a neuropathic component as well. So it will actually help us in managing bone pain better because we have specific agents for which primarily help in neuropathic pain also. This is one thing I wanted to mention because although it is classified under somatic pain, there is usually a neuropathic component associated with bone pain as well. So somatic, visceral, neuropathic and nociceptive and neuropathic. Nociceptive, the somatic and visceral. Neuropathic is obviously no. So I think I hope it's clear. So visceral pain, as I mentioned earlier, usually occurs in response to obstruction of any hollow viscus. So it can also occur as a result of injury to other pain-sensitive visceral structures like visceral pleura, hepatic capsule, peritoneum, etc. It can also be treatment-related. It need not always be disease-related as well. A classical example would be some adhesions following a surgery for tumor, following radiation, all those things. It is typically described as colicky twisting pain, but that may not be always the case because visceral pleura, hepatic capsule pain can be perceived in a different way as well. So since we have just classified the pain in a broad sense, let us come to assessment of pain. So the idea of assessment is to manage the pain, right? So before going into the assessment, it is beneficial to keep the treatment in mind. So in palliative care in general, we generally say three principles for proper treatment. So one is correcting the correctable, second is non-drug measures, and third is drug for symptoms. Correcting the correctable is anything that we can correct, which will actually improve the symptom of the patient or the quality of life of the patient. We should do that. So it doesn't mean that palliative care is only symptomatic management. We are always giving always treating the symptoms and we are not doing anything proactive. That is not right. So if anything, correctable is there, we can actually improve in the quality of life. By all means, always do the correct the correctable first. Second thing would be non-drug measures, any other things that will help with the symptoms of the patient. So third would be, if anything, I mean, nothing works, we'll obviously have to give drugs for the symptoms. So all these things comprise the management of all symptoms, and same with pain. So coming to the assessment. So aims of assessment would be to assess the characteristics of pain, pathophysiology of pain, etiology of pain, and other factors contributing the pain experience. So before going into the assessment, so there I would like to give 3 concepts to keep in mind before we assess any patient for pain. The first thing would be listen. So I'll just play a video, which is the words of Dame Cicely Saunders, as I mentioned earlier, considered as the founder of palliative care. So you will just listen to the video.
I'm often asked, what is the first thing you really want to say to somebody going into medicine or moving into palliative care? What is the major commitment? And I'm sure the answer is simply listen to your patients. They'll tell you. They'll tell you what they need. They'll tell you who they are and what they can achieve.
So the first point I would like to stress is to listen. So I mean, when I came into palliative care first 3 years back, one of the exercises my HOD gave me was to try to see how long I can actually listen to a patient without interrupting him or her. It's actually a very interesting thing to do. So you can all try it sometime. It is really surprising how short our attention span is, and how difficult it is to go on for at least a minute without interrupting the patient. So the thing is, actually, if we just allow the patient to go on for some time, so he or she will actually tell you what is worrying her. And the second thing would be to believe. So as I mentioned earlier, the pain is very subjective, and the pain has multiple dimensions. So it is always right to believe the patient. If a patient says that he or she is in pain, it is right. So pain is what the patient says hurts. This is actually a quote from Dr. Robert Wycross, one of the pioneers in palliative care. Yeah, so belief is the second thing that I wanted to stress. So third thing would be to have empathy and compassion. So just let the patient know that you are there for him or her, so that you have that rapport, and the patient will be comfortable in sharing his or her issues with you. So that is another important thing. So listen, believe, and have empathy and compassion. The third thing would be to assess the characteristics of pain. So we have a usual mnemonic known as the PQRST. It says that P is palliative factors, which improves the pain, and provocative factors, quality, radiation, severity and impact, and temporal factors. So the mnemonic says PQRST, but we usually go reverse. So basically, palliative factors is which all things that improve the pain. Provocative factors, the factors that increase pain. Quality, as I mentioned earlier, will give us an idea about the type of pain, whether it is a dull pain or aching pain, throbbing pain, radiating pain. So radiation is where the pain goes. It will actually give us an idea whether the pain is neuropathic or not. Severity and impact, how severe is the pain and how it actually impacts the patient lives. Temporal factors are the time-related factors. When was the pain first started? How the pain has progressed over time? Whether there is a variation of pain with time. When is the pain increasing? When is the pain increasing? Decreasing? All those things. See here, as I mentioned earlier, quality of and radiation. These things will give us an idea about the type of pain, whether it is neuropathic or somatic, visceral pain. So palliative factors and provocative factors will actually help us to decide on the management. So if we know that what are the things, the things that are improving the pain, we can actually, or the things that are increasing the pain, or the things that are decreasing the pain, we can actually tailor a plan of management for them. Severity and impact is very important because we prescribe the analgesics according to the severity of pain. We'll come to that very soon. And temporal factors will help us time our intervention. So all these things are important in deciding our management. So just keep those in mind. So as I mentioned earlier, we typically prescribe analgesics according to the severity of pain. So assessing the pain intensity or the pain severity is very important. So for that, it is very important to have something like a recordable scale or recordable thing for pain intensity. So it's not like the patient will come and tell you, I have moderate pain, I have severe pain. So it should be quantifiable, and it is something that can be followed up. So for that, there are some pain scales or tools for assessing pain intensity. So these tools can be divided into unidimensional tools and multidimensional. Unidimensional tool is basically just asking the patient how severe is the pain, nothing else. So you'll just ask the patient how severe, and all these various scales or various ways of recording the severity of the pain. So there is only one question asked: how severe is your pain? Multidimensional scores will actually branch out. It will actually explore the various aspects of pain, how it affects the daily living, or what are the different components of the pain. All these things will be assessed by multidimensional pain assessment tools. So I'll give you some examples for unidimensional pain. This is the most commonly used numerical pain rating scale. So what happens is, here, this is a linear scale. It ranges from 0 to 10. So 0 is no pain and 10 is the most severe pain imaginable. So scale is from 0, 1, 2, 3 up to 10. So if the patient will be asked to give a number to his or her pain. So 1, 2, and 3 are classified as mild pain, 4, 5, 6 as moderate pain, 7, 8, 9, 10 are classified as severe pain. So what we do is, we actually record the pain at the first visit as a numerical scale, and each subsequent visit we'll ask the scale again, so that we can actually track the progress. So we can also ask, it need not be a single question, we can ask the highest pain, what was the pain yesterday, all those things can be asked. So this is just an example of a numerical pain rating scale. It is a unidimensional pain scale. Another thing will be visual analog scale. So this is just a straight line starting from no pain at all to excruciating pain. The patient will be asked to mark a point in this line according to the severity of his or her pain. It works almost similarly like the numerical pain rating scale, and each visit the patient will be asked to mark again. Another example of visual analog scale. This is another scale which is known as the Wong-Baker Faces scale. It was actually primarily developed for children where they cannot effectively communicate the severity of pain. So this will actually take into account the physician's perception of the expression of the patient. So it has 0 to 4, basically various stages of pain. So according to that, we can actually grade the pain according to the patient's facial appearance. So this is now even used for adults. There is actually a separate website for this Wong-Baker Faces pain rating scale also. This is another example of a unidimensional pain rating scale. So coming to the multidimensional tools, one example would be McGill pain questionnaire. So this is the entire thing. The first thing that came out, it actually came out in 1975. This was the first document that came out. This is a short version. So you can see that here they are asking the type of pain in detail and how it actually affects the daily activities. And you can also mark the site of pain here. This is a little bit more of an advanced kind of exploring kind of questionnaire. So we actually ask about the various aspects of pain also. Another example of a multidimensional questionnaire would be brief pain inventory. This actually came out in 1983. This is a short form of it. So you can see that here they are actually asking about how the pain affects the general activity, mood, your walking ability, relations with other people, all those things. So it's a little bit of more of an exploratory kind of questionnaire. The problem with multidimensional questionnaire is, one is time factor. If you, this will take some time. And again, you have to make the patient understand all these things. So it may not be very practical to use it in everyday practice for all patients, but especially for research purposes and all, this is quite useful. So another thing that we usually use is the NCCN distress thermometer. So since we just, this is not used routinely for everybody, but it is worth mentioning because, as I mentioned earlier, pain is not just a sensation. It's a very broad experience. So this is basically like a way of assessing the patient's distress. So it goes up to this. This is a thermometer. Goes up to no distress and to extreme distress. So this is not typically a pain assessment tool, but something that you should be aware of, so that it will be worthwhile keeping it in mind while assessing the patient. basically we are trying to assess the distress of the patient. So again, there is a separate explanatory questionnaire also regarding the cause of this distress within these patients. So a word about temporal factors. As I mentioned earlier, in the assessment, we'll ask about temporal factors as well. So we ask about when the pain started and how the pain is progressing over time, how the pain is during various parts of the day. So one important thing to keep in mind is that, especially in people with chronic pain, there are two components of pain. One, there will be a chronic background pain, which is usually constant, and in between there will be spikes, which is called the breakthrough pain. So whenever we are prescribing analgesics, it is always important to prescribe analgesics at a routine interval. So you usually prescribe as 3 times a day or every 6 hours or every 4 hours. That will actually take care of the background pain. But you should always prescribe SOS analgesics for this breakthrough pain. So one factor of chronic pain, as we mentioned earlier, is it fluctuating cause. It may not be constant always. There will be breakthrough pains in between. So in the temporal factors, it is also important to assess this breakthrough pains and prescribe SOS analgesics to this patient. So just to bring that to your notice as well. So the million-dollar question is, do we underestimate pain? So we have talked about pain, how to assess it, and how to scale it and all those things. So question is, do we underestimate pain? The answer would be yes. I'll just quote 2 studies. There are multiple studies. So this study by Grossman et al. So it has shown that when patients rate their pain as moderate to severe, oncology fellows fail to appreciate severity in 73% of the cases. I'm not criticizing oncology fellows in any way, but just a study, because in 73% of the cases, the doctors actually failed to appreciate the severity, especially in moderate to severe pain. Another ECOG survey showed that the discrepancy between patient and physician evaluation of severity is a major factor in inadequate relief. So yes, we do underestimate pain. So see, another interesting thing to notice is that it is not only related to the general, the specialties other than palliative care. See, this study has been done in a palliative care center, in a hospice, where the primary aim was to, the primary aim in palliative care and especially in a hospice is to provide as much comfort to the patient as possible. See, we can see that pain was underestimated in 46% of the patient, 46% of the patients, and half of all these underestimations were clinically meaningful, compared with only 28% of the pain was overestimated, but 46% of the pain was underestimated. So again, as the pain score goes up into the moderate to severe territory, pain underestimation was both clinically and statistically significant. Yes, we do underestimate pain. So that brings us to our previous point, self-report is the best report. So why do we underestimate pain? So we estimate pain because we assume, right? So again, I'll quote Dr. Robert Wycross in his book, Introduction to Palliative Care, Introducing Palliative Care. He says to assume is to make an ass out of you and me. So we underestimate or overestimate because we assume. So if we believe what the patient says, this will not happen. So once again, I would like to stress the point that self-report is the best report. And second thing would be use help. So see, the thing is, it is, as I mentioned earlier, pain is not a single unidimensional sensation. It has multiple modalities. So we may not be equipped enough to assess the pain in a very, very systematic way. So use help whenever possible. Whenever available, use the help of other medical professionals also, in the sense, use the help of nurses, doctors, whichever professional you are, help of nurses, social worker, psychologist, everything. Use help whenever possible. So then only we will be able to understand pain in its real sense and to do justice to the patient and to the symptoms. So with that, I would like to stop my presentation. So I see this is nothing going into the details of pain, because you will have multiple sessions on pain in the coming days, which will go to the various aspects of pain in detail. This is just an overview. So if you don't remember anything else, and I would like to just give you a few points to take home. First, as I mentioned earlier, pain is subjective. So always listen, believe, and be empathetic. Self-report is the best report, as I mentioned earlier. Always believe the patient and use help whenever is possible. And I hope that you'll all be able to treat pain well. Thank you.
Thank you, Dr. Jewell. Radhaman?
Thank you very much, Doctor. See, it is very, very essential there is an important element, as he mentioned, IASP, that is the International Association for Society of Pain. In 2020, they have added those 6 factors what Dr. Jewell Joseph has mentioned. So we have to give importance to the patient or person's personal experience, which has biological, social, psychological element. So on top of the definition, they have added 6 points, which 6 points is what he has mentioned. It's a subjective one. We have to respect the person who is complaining that it is painful. And then, and now, last but not the least, is verbal expression is not the only way. So everything has to be equally respected and considered, so that the it is we respect, because it's a subjective phenomenon. We have to understand, and what every one of us have to take home from today's session is that we have to give importance to every element of it: physical, emotional, sensory, experience element, everything is there. And also explaining, see, what we have understood today has to be explained to the patient, that okay, you had the injury once, but it can have desensitization element in it. Basically, it is amplifying. So that is what it is doing. So what is happening within has to be explained to the patient, and that will give a very good benefit for all of them. So overall understanding will be better. So the main element of this redefinition was that to help in understanding, management, and end of the day giving a better care. So what is that? Internationally, this is the trouble, and pain forms the maximum chunk of palliative care, and it is considered as the 5th vital sign. So there are so many important factors. So that is why, see, in our session also we are going to have 3 sessions minimum for pain, because it is an important thing, and understanding this important basis, that is the physiology and pathophysiology, is very important for us to manage and treat. So it is very, very important, and well done. You have approached everything very well. And this is all of you, what you've learned today, to brush up everything and keep that in mind for the following 2 sessions. Because every element, so whatever physiology and pathophysiology, what we have covered today, is what we're going to use in the management again. So assessment, only one thing I would like to add is assess, reassess, what he said. And every time when you're reassessing, see, for example, your primary pain score was 8. And then with the management, we have to be prepared to face both. It could come down to 2, or it can stay at 8 also. Don't be worried for both. Okay. So if it comes down to 2, what we have done is fine. Yes. Okay. Go ahead. That progress is good. Oh, or else if it's not coming down, no issues. We'll use other supplements or what, or we will go back to the diagnosis. Are we hitting the right point? So that is what. So whatever it is, assessment, reassessment is what will give success to all of us. Okay. So, and using the same whatever score and these charts and things, what is available regionally and what is feasible and what is best for the patient. Okay. Tailor make to your needs. Don't worry. Whatever you have, you can do the best. So use what is available in your particular hospital. And then if any regional language differences are there, you make it to what will suit for the patient. Okay. And because only if you convey properly, you're going to get the best. We have seen again and again subjective. So if you don't convey, how are we going to get the best? So that is how it has to be taken. And then either we can have some discussion now, or go ahead with the case presentation and combine both and do. If you have anyone has a burning query to be asked immediately, go ahead, either unmute and ask, or type in the chat. Either way is fine.
Ma'am, I have a question. Dr. Tribeni here.
Go ahead.
In the pre-test, it was there. One question is that pain is best assessed by patient or by nurse and doctor, and 2-3 options were there. So I think what I understood from my thing that pain is not only physical and emotional. Everything comes together. What patient feels, it's much more.
Yes,
because
that's it.
the traumatic thing is there. So definitely the patient is the best one to tell, because pain threshold for each one of is different. Like we know, like some people have tooth pain, or basically we commonly we say male, they have, like whenever they have toothache, they say it's very unbearable. But when the female, they go through the labor, they have to bear the pain. So when we compare that, so pain is definitely a subjective, and we can't really tell that how much the pain is. Only the patient can tell.
True. That's the take home from today. What did he complete telling? So that is what was his message. So you took the message and understood it very well. So Dr. Jewell Joseph will be very happy. Someone there has understood that. So exactly true. The main thing is that the pre-test is also what for us, for you all to have an idea of what it is. And after attending the course, have I got more information and am I better off? And that is what we are looking at. So
Thank you,
fine.
ma'am.
So yes, I totally agree. Subjective element and individual variation, individual pain threshold, everything has a big role. And that next is individual pain experience, individual beliefs, individual customs. Everything has a role. That is why social, biosocial, psychological element is there to the pain.
Thank you,
Fine.
ma'am.
So in agreement, no problem. So shall we go ahead with the case presentation then?
Today we have a case presentation by Dr. Surabhi. Dr. Surabhi?
Yes, ma'am. I hope I am audible.
You are audible, ma'am, please.
Okay, good evening, everyone. Myself, Dr. Surabhi. I'm dentist and practicing in Chhattisgarh, India. Now I'm presenting my case. I have patient, 37 years old male patient, diagnosed with squamous cell carcinoma in buccal mucosa in staging 4A on the basis of clinical examination and the biopsy. Pain and swelling in lower right back region of jaw since 3 months. Reduced mouth opening is present, excess salivation and halitosis. Coming to the history of illness, ulcer was associated with pain, which was 6 out of 10 based on the VAS scale. Pain is localized, moderate, intermittent, and non-radiating type. The pain aggravates during mastication, which is lasting for few minutes. Sometimes the patient takes medication for it or the pain relief by its own. Ulcer bleed during brushing, and there is no history of recurrent ulcer as well as ulcer present um, only in the oral cavity, not any other site, and there is no history of trauma. On the basis of examination, I just told based on the VAS scale, it is 6 upon 10. It reaches up to 8 out of 10 during the mastication. It is a physical pain. Also bleed on touch or during the brushing. Fistula formation is there and also is indurated. Physical, as earlier sir told, not total pain is combination of physical, psychological, spiritual and socio-economic. My patient has a bleeding ulcer, painful ulcer, restricted mouth opening, where he is depressed and worried about the family. Spiritual, he always asks, why me? If I pray, I recover. Decline the faith in the life. Financial crisis is acceptance of the society is low. As a routine investigation we done, and he has a hemoglobin 12 gram, RBC is 4.85 milli per cubic mm cells, and platelet count is 3.03 lakh. And we go for the biopsy, and the biopsy report suggested as epithelium invaded the underlying connective tissue, stroma in the form of keratin pearl, large island, hyperchromatism, and altered nuclear cytoplasmic ratio is highly suggestive of the squamous cell carcinoma. Psychological aspect, 37 years old married man with the 2 children, respectively 5 years and 2 years old, living in the village. Primary and only source of income is patient himself, his farmer. 2 sisters, both are married and live in the nearby village. They support him emotionally, but financially they were not able to support much. He is not able to visit hospital on the regular basis because of distance, economics, and there is no proper transport. Plus, he has to go field regularly for the work. He lost his both parents. Both children are young, worry about their futures. Neighbor and friends are there for him and give financial support as much as they give. As a doctor, we give the painkiller like diclofenac with the sedatio. We don't have the morphine or opioids in the tablet form, so we prescribe buprenorphine patch, antibiotics, and Pentoff, and mouthwash like chlorhexidine twice daily, diluted with the water in the ratio of 1:1, and patient was referred for the surgical process. Main concern is pain and reduced mouth opening, money or expenses for the surgery and further treatment, children and family. Summary: 37 years old man with ulcer on right side and diagnosed with a squamous cell carcinoma grade 4 and referred for surgery. Not only physical pain, he also experiencing helplessness, loneliness, and depressed. And discuss about the psychological support or help, economical medical advancement, and wave portal. Thank you.
Thank you,
Okay,
Dr.
here,
Surabhi.
just thank you very much, Dr. Surabhi. Ideal
Thank
case
you,
you've got,
ma'am.
and then you have given us an idea of what is that is essential in assessment. So today, as we have got 3 sessions on pain, it would be nice if we stick to the first element, that is the introduction, what we have covered in our topic. See, if we go into treatment, we are going to have our next two, like we will have 2 more sessions on pain itself.
Yes, ma'am.
So it would be ideal if we could stick our discussion and all our thing to the initial, what is pain, what is the type of pain he's having, how are we going to assess him, total pain. Those are the things which we will concentrate on the discussion today. Why am I telling it straight away? Because so that we don't digress, we stick to our point and have a detailed discussion on that topic. Hope that's okay.
Okay, ma'am. Yes, ma'am. Okay. Thank you, ma'am.
All of you can either type on the chat. See, total choice is yours. Either type on the chat or unmute and ask, whichever you feel comfortable with.
Hello, ma'am. Dr. Tribeni here again.
Go ahead.
Yes, what actually we should do, because if someone is a private practitioner or whether it's a government, because as a clinician, we will not able to do anything much. So how does societies like Pallium India or Indian Palliative Care Association, how anything can we what is how we should do? Means I'm just starting this course, I don't have much idea. What is the thing we can do for this type of cases, ma'am?
No, first thing is that assessment can be done by anyone. Okay, for that. So main thing of you gaining knowledge is that first to understand what exactly is the pain. Okay, first element of it. And the assessment part of it, you can go into the detail. What is the nature of pain, type of pain, extent of pain, aggravating, relieving factors, what was mentioned. So you have to, like you go about with any symptom, like for example, fever or anything, you have to go about with the pain also in detail and then assess. And then see, next thing is that not everyone will have access for everything, but at least you can have a basic element of what the problem is, and then appropriately treat and get the help. See, always we have to be prepared to refer them, because for us always ultimatum is best interest of the patient is the aim and goal. So how are we going to provide best care to the patient? So you may not be able to provide everything. So next is to you to find out which is the nearest referral oncology or a palliative care unit where you could refer them. Because we should not deny any care to any patient at any point of time. one person may not be able to do everything. That is why the cornerstone of today's care or treatment in multimodal management is what will help. So especially with pain, as we have seen in our main faculty presentation, the underlying background depression or any other element of emotional element is also to be considered. So you have to give importance for that also. So the emotional element, what is the patient all right, emotional, financial, because see, even the pain is aggravated by the background worry that is going on. So you have to do the clinical assessment to what extent it's possible, and then get the help or refer them to the nearest hospital to what is possible, and then take it from there. See, overall, the total pain, managing the total pain is what it should be your aim and goal. So what is possible by you to be done, and then there are more, either a private or a government setup of palliative pain and palliative care facilities are increasing, and more people doing and attending that. Collectively, organizations can set up and start new pain and palliative care services also.
Ma'am, what about this economical medical advancement and web portal? This is it's a website or web like discussion point. It is there in this economical.
We should
medical.
ask Dr. Surabhi if there is anything specific about that, or is she asking?
Mostly, I have personal idea about that. We have to something like Google or some connection, so people can take the help from the web portal.
Okay, telemedicine or like consultation, or if needed, someone who can NGO or who can help this type
we
of.
connect through the web
basically.
And
Go ahead.
Yes, ma'am. But we
Yes,
can,
ma'am.
just we can connect all over India through the web, and we get the treatment or whatever we need.
Yes, understood.
Basically, see, this is something. No, reaching out, thinking outside. And if there is an NGO available, can we link the NGO with the patient or the family who needs support? So we are trying to link. The need is there. Is there a supply which can meet that need? Okay. So this is going. This is an additional attempt, or it's a well-wisher type of thing.
Yes,
Exactly.
Okay. Thank you, ma'am. Thank you, Dr. Surabhi.
No problem. Well, let
Thank
me
you,
see.
ma'am.
There is in the chat we have got. We will start with assessment of pain.
Can I?
Go ahead,
Miss Dr. Sheena. Hearing from the patient history, I feel this patient definitely need a definitive treatment, and along with that, the post-surgical treatment of post-radiotherapy, whichever, as per the oncologist assessment. So once the patient he underwent surgery, he will require, we have to reassess the patient, how much pain is there. Pain may be reduced, but still he will have other problems like feeding and nutrition, taking care of other issues. So it's a wholesome treatment. We have to such a patient we have to advise. So we have to connect with the definitive treatment with palliative care. So both should go hand in hand, I believe.
Yes, definitely. Correct. Always, whatever corrective management, surgical management, whatever is accessible, possible, has to be done. And even if it is a curative one, fine. Many times we do palliative radiotherapy, palliative surgery. Anything that can be done to ease with the pain has to be done. There again, resource availability, everything has to be considered. Like as someone has brought up in the chat, like whether financial or access problems are there, you have to deal each patient according to that situation. So as you mentioned, yes, definitive treatment also has to be considered. Along with that, you look at all the various types of as I said, no, we will go into the WHO ladder,
Yes.
adjuvants, everything in detail in our next sessions. So we will deal with that. Appropriate, adequate medical management will also be done. Along with, as we have mentioned today, we will have the non-pharmacological management options also.
Okay.
And so everything will be considered to the need of the patient.
Okay.
Need of the patient, need of the case, everything accordingly. And coming to, hope
Good
that
evening,
is
ma'am.
answering your question. And there are a couple of questions in the chat. Of them,
Ma'am,
the first, yes.
this is Dr. Shivranji. Actually, I have a patient who had a, cerebral atrophy and he's quadriplegic. He has bed sores. He's actually very depressed. So since he's very depressed, his bed sore is very deep, and there was pus and all. We got treated and everything. But if you ask him every time, like, how is your pain? Do you have pain? He never answers. He always says, I'm okay. So that's the only thing he says. So, but there was infection, there was pus, there is a deep wound. So how do we assess in this patient? How will he?
No,
Because it is
see,
self,
for him,
it's not
that's
telling
why
us.
there are separate, as Dr. Jewell Joseph mentioned, there is something other than, like, there is something called as depression. HAT score is there. So you have to get the help of either a psychologist or you that is why, see, in these type of situations you have to go one step ahead and you have to assess their sleep will be disturbed, their emotion will be disturbed. But if they are so depressed, they may be in total denial. He is not revealing anything to you. That is why. So that has to be assessed separately. And once you go into that assessment, then they will open up and tell everything. You will see a different picture. So you may need some psychological assessment done for him. Either a clinical psychologist or a psycho-oncologist or some type of psychological assessment. There are scales and things also for that. That if you do that by yourself, you will get an idea, but he will need some extra support from the psychological team.
Actually, he was
Yes.
not getting admitted anywhere. We had sent him to a government hospital. Nobody wants to accept him. So and his financial condition is also bad. So with the help of insurance and everything, so he's only in this hospital, and he's been getting treatment for a month or so now. So that's why, like, we are not able to get help from somewhere else. So probably
I totally agree, because everywhere resource limitation will be there. Many places you may not have a psychologist. And that also could be there. So those type of things you then have to find out if there is another referral place. And then with these financial restrictions, if they are there, then we have to find out what will be the situation for managing his condition appropriately. So see what will be the nearest, what will be the nearest available center for his counseling, or if resource limitation is there, if somebody else could volunteer to help him. Those are things if it is possible, and that would be the way forward. And regarding the questions in the chat,
thank you, ma'am.
Then welcome. And so there was is the question that will sleep be disturbed by pain? Definitely. If that was the query, it will be, because we normally ask that as one of the question. Is your pain disturbing your sleep? Are you able to sleep properly? Okay. And next question is, for patients not accessible to higher institutions, what can we do to the next level medication? See, again, the availability of medication, what is available, what could be made available, or you can refer them to a place where the medication part will be dealt. We have a regular, we will follow the WHO ladder, and when we get to that session, you can come back with the question again, and we will deal with that. That would be more appropriate. And as you have said, suggested specific. Next is availability of medication at your local regional area for us to see where we can go from. Next, assessment of impact of pain on mood, psycho-emotional state, quality of life. Are there any specific tools for assessing this? And does Dr. Jewell Joseph want to answer anything specifically to that question?
Yes, ma'am. The multidimensional tools we mentioned in that presentation. So they have these questions: how does it affect your mood? How does it affect your day-to-day activities? Psycho-emotional states. All those things are there. There are specific scales for assessing the psychological status of the patients also, like ma'am mentioned. Yeah, the multidimensional tools like McGill Pain Questionnaire and Brief Pain Inventory, they do have these branchings. How the pain impacts the various activities of day-to-day life and mood and other psycho-emotional states of the patient also.
See, thank you, doctor. And the distress thermometer is something which is commonly used.
Yes.
Okay, that is a simple, like we have the visual analog scale, like 0 to 10. That distress thermometer is something which comes very, very handy. Okay, see, we have multiple tools. Again and again, I can keep your life simple. You, rather than having 10 tools, have one tool at least, and then identify what the issue is and take it from there. So if you identify that there is some distress, first, fine, and then go again on into the in-depth assessment of that. Then what is the cause of the distress? Is it physical, psychological, emotional? Put every element into that and then take it from there. Then based on that, see, there are umpteen tools and scales. You have one for each specific disease. You may have someone with psychiatric issues. So there are specific ones. Dementia patients, there are separate tools. There are plenty of disease specific tools also available. Diabetes, that is one of the common neuropathic pain causing issue. So for that, we have an extensive tool. So there are many tools available, yes, but you see what is needed for that particular patient and have some basic element and then take it from there.
Exactly, ma'am. Just to add, completely agree with ma'am told. So rather than following these tools to the T, so you can basically take them as guidelines and tailor it to your specific needs or the particular set of patients that you are dealing with. So the all idea of all these tools is something that can be reproducible and something that can be followed up. So that so take these as guidelines and feel free to modify it according to your needs. Thank you.
Exactly, that is how these guidelines itself are made. Okay, all these guidelines are made mainly, you have them. Then see, regional, area wise, so like cultural difference, you have to use it according to the local area and what is best for you and the patient. So take it like that, and that would be the best way forward. Regarding medications and things, because we have the other sessions, even the availability of medicines, I would say we will go about with that in the following sessions when we have that as the main topic, because that will give more insight for us. So mainly, I would say the important things to be understood mainly are, it is just not physical injury. We have had a clear explanation. Tissue damage or injury could be a very minimal one. I normally used to say that even there need not be a cut injury or anything, even shear and strain, shear, stress, strain. Like for example, in surgery, no, you may have surrounding, there may be no nerve injury, but surrounding or stress and shear, what happens at the time of surgery is enough to cause all these symptoms. So understanding and explaining what you have all heard today is the most important thing. As long as you all have understood what it is and you are clear enough to explain to your patient what it is, that is the most important thing I would stress, which has to be taken into consideration. because that is what forms even in any form of treatment, this forms a big chunk. Understanding, explaining, and assessing. Then your treatment option will definitely be good. And then always reassessing as often as required, so that you are keeping on top of. See, main why reassessment? Are you going in the right path? If not, go back, retrace. What is that change has to be done? That is what is the important thing. Various scales, and these scales mainly help the patient to express better. Whereas the Megel pain question, where you have the body, whole body depicted there, so they feel free. Oh, this is where I have the pain. They can mark on those charts. So those are type of things which will come handy for them to express, because so they will not have the feeling that they are deprived of expressing anything. That itself will give them an emotional satisfaction. Your listening bit is covered in that. So those are so everything matters. How you see the patient-doctor relationship, what you're going to have, this is what builds it. So if you're listening and looking into everything, and they will open up, even the psychological and emotional element, which they were not initially thinking of revealing, they will spontaneously reveal things to you. Good. See, the main thing is that the discussion, like any queries and things, as long as we have a healthy discussion and clarify all your queries, that would be a better way forward, so that things are clear for you. We have most of the queries mentioned, we have clarified everything. Go ahead.
Ma'am, if there are no further questions, shall we wind up?
Yes, that's what. If that's why I've checked the chat box also once again. We have clarified everything. Before we wind up, hope does anybody else have any query, burning question? As I said, we have few more sessions in pain. We will go into the in-depth management of different types of medications and difficult pain. Also, we have a separate session. We have everything which will be dealt with in detail. Other than not only query with it, with the start of the session and things, hope, do any of you have any other queries in the couple of sessions that we have had so far? If not, we should be okay to wind up, and I hope all other instructions and things are clear. Thank you very much, Dr. Jewell Joseph. You gave us an excellent insight into everything, because that is what is very important, to understand the topic well.
Thank you so much. Thank you for guiding the discussion.
Thank you all. Special thanks to Dr. Jewell Joseph for being with us today. Thank you, Radha ma'am. And there was a query in the chat box asking for the slides. All the learning materials, including the faculty presentation, will be uploaded to the IECO LMS platform soon with a video link. So you can go through it again. I have shared the feedback with all of you. Please go through it and fill it up. Thank you all. We'll see you on the next session. Bye.
Thank you, one and all.
Thank you.